Welcome to this podcast. I'm your host, Dr. David Henry. You're listening to Blood and Cancer and MDedge.com/hematology-oncology product. And we're doing a special edition, as we did last year, about the SABCS, the San Antonio Breast Cancer Symposium, but I'm not doing it alone. As we did last year, I'm joined by my longtime friend and fellow, way back in time at Penn, Dr. Alan Lyss, who is sub-principal investigator, sub-PI, at the Heartland Cancer Research NCORP, and associate professor of clinical medicine at Washington University. Alan, welcome to this annual San Antonio Breast Cancer Symposium talk.
Thank you, Dave. I'm really honored to be here with you.
Well, my pleasure to always work with you. So we'll get right to it. You and I have a nice lineup we chose of 10 abstracts, and Alan's going to go first. So without further ado, Alan, why don't you do your first one?
Very good. And Dave, the first one that I wanted to review was abstract GS3-07, identifying patients whose symptoms are under-recognized during breast radiotherapy. And I'm embarrassed to say it, but I initially kind of went to sleep about this abstract. I thought it was good, but the more I thought about it, and the more times I heard Dr. Jogsey, the lead author, respond to questions, the more impressed I was that this could be one of the most important stories to emerge from San Antonio this year. And let me explain that. Obviously, the accuracy and depth to which patients and physicians communicate with one another is very important in every conceivable aspect of oncology. Regarding communication about adverse events from treatment, it's really particularly important because accuracy about the toxicity that our patients are experiencing enables us to implement the right kind of supportive care, right amount of supportive care, and potentially enable patients to complete a planned course of therapy and benefit from it. Also, clinical trials historically have relied on physicians' assessments of toxicity and making judgments about the risk-benefit ratio from new treatments. So what they did in this study was investigators from a multi-center consortium of 29 academic and community institutions in Michigan enrolled over 13,700 breast cancer patients who were receiving breast-conserving radiotherapy over an 8-year period of time. They asked the patients to report their symptoms during radiation via questionnaires, and they asked their physicians to complete standard CTCAE toxicity assessments within 3 days of the patient's office visit. Almost 10,000 patients completed at least one questionnaire. Now, the investigators were specifically asked about how the patient-physician pairs reported 4 symptoms. And the 4 symptoms were pain, pruritus, edema, and fatigue. Their criteria for symptom under-recognition, in my view, was really very generous to the healthcare providers. For example, physicians were deemed to have under-recognized pain when the patients reported moderate pain that the physicians recorded as no pain at all, or when the patients reported severe pain that the physicians recorded as no more than mild. Similarly, physicians were deemed to have under-recognized pruritus, edema, or fatigue when they recorded those symptoms as non-existent, and the patients reported having been bothered often or all of the time from itching, swelling, or tiredness. And what they found was over half of the patients had at least one moderate to severe symptom. About a third had substantial breast pain or pruritus. About a quarter had moderate to severe trouble with edema or fatigue. But remember, the goal of this study was to assess whether there was under-recognition of symptoms by the healthcare providers. And they found that under-recognition of pain occurred about 30% of the time, pruritus about a third of the time, edema about half the time, and fatigue about 20% of the time. Of the patients reporting at least one substantial symptom, more than half did not have their physicians report that symptom accurately. Now, to evaluate predictors of symptom under-recognition, the investigators performed multivariate logistic regression analyses, and they found that race, age, and radiotherapy regimen were associated significantly with symptom under-recognition. For example, patients younger than 60 and especially younger than 50 had increased odds of symptom under-recognition. Compared with white patients, Black patients, get this, had a 92% increased odds of symptom under recognition. And patients of races other than Black or Asian had an 82% increased odds of symptom under recognition. To some extent, patients who did not have supraclavicular field irradiation or who received conventional fraction radiation had more symptom under recognition than patients who received hypofractionated radiation, but that association was moderately weak compared to the others. And why this is important, and I believe it's important on multiple levels, is that, as you know, and as our listeners know, physician-patient communication is at the core of our relationship. And if we're not communicating with one another as something as basic as symptoms from treatment, we have a serious bidirectional problem with our patients. Secondly, this is an issue that transcends the specific example that was studied here. Symptom under recognition has also been seen in patients getting gastrointestinal radiation. And in an era in which patients are receiving more communication with telemedicine, we need to be especially proactive about addressing this aspect of our relationship with patients and their openness with us. A multivariate analysis suggests that physicians and other caregivers have potential unconscious biases, and different patients may come to us with different expectations of the interaction, and they may be more or less forthcoming with us. Fourthly, symptom detection is a targetable mechanism to reduce disparities in health equity. Better recognition of and acting upon symptoms the patients have from our treatments is one way in which physicians can improve health equity. All of our institutions say that they're interested in health equity. This is something that we can do to actually promote it. And finally, with regard to clinical research, and really with regard to clinical practice, patient-reported outcomes collection appears essential from this study. It's not going to be easy to implement in routine clinical practice, but it's likely going to have benefits far beyond what Jogsi and coworkers found in their study. I know you recall, because I think you and I were together, the plenary presentation at ASCO 2016 by Dr. Ethan Bosch and the subsequent publication in JAMA showing that there was actually improvement in survival from implementation of PROs at a major cancer center. And I think the bottom line here from this abstract, and I'll wind it up, is that we've got to do better at this. And the first step in correcting it is to acknowledge that there's a problem. And this abstract really established that.
Well, I'm thinking the whole time you're talking, presenting, PRO keeps resonating in my mind, and that is under-collected, I'm sure. Every study we could do, similar to the one you just said, would show the same thing. And until COVID came, tablets in the waiting room were kind of coming to our center, but now people can't take too close together. It'll capture symptoms better, but I think it's a really underappreciated area and a nice abstract just presented. So I agree, it's really key. Let me go next. And I chose next GS2. And so our listeners, GS took me a while to figure that out. It's general session 2 and 03, the abstract number. The title, Prime 2, randomized trial. And here's how they got the acronym: postoperative radiotherapy in minimum risk elderly, wide local excision and adjuvant hormonal therapy with or without whole breast irradiation in, I was a bit offended here, elderly is 65 or older. When did that happen? With early invasive breast cancer, 10-year results. Dr. Ian Kunkler presented that, Edinburgh from the UK. And it was early stage breast cancer who were on systemic therapy, typically hormone, and they either got or didn't get radiation. So it was 1,326 patients. Who were they, besides the age I gave you? They were T1 to 2 up to 3 centimeter, lymph node negative, of course, metastatic negative, and they're ER positive. They could have grade 3 tumor or lymphovascular invasion, but not both, interestingly. Their primary outcome endpoint, ipsilateral breast tumor recurrence, they call it IBTR, ipsilateral in-breast recurrence. And their results at a median of 10 years, the in-breast tumor recurrence was 9.8% in the no treatment arm, and in the radiation arm, 0.9%. Very different statistically and numerically. Progression-free survival, 12.7 for no treatment arm, 6.6% in the treated arm. And overall survival, and here's where it kind of came down to, gee, is this a big deal? 98.2% no treat, 97.8% treat. So I thought, you know, the numbers are striking. Remember that 9.8% versus 0.9%. But the others concluded, and I guess I agree, doesn't impact overall survival. So to me, it just says it's a discussion. You're having elderly, so 65, 75, 85, how old is the patient, how frail? You might omit radiation if systemic therapy is being given otherwise, and go through this potential for in-breast versus overall survival. No difference. So I thought interesting, and just leads to another discussion in the office.
It seemed to me about that one too, Dave, that one needs to be very sure that the patient's going to be adherent to their hormone therapy regimen if they're going to avoid the radiation.
All right, so then I think next back to you for two abstracts.
Yeah, the first one I wanted to bring up was GS1-01, General Session 1-01, the primary outcome analysis for monarchE, a study of adjuvant abemaciclib plus endocrine therapy for high-risk early breast cancer. And as I mentioned on a prior podcast, it's really a mortal wound on several dimensions when women who present with early breast cancer and favorable features experience a likely incurable distant relapse of their cancer. But unfortunately, that happens about 20% of the time, depending upon the clinical circumstances. Since CDK4/6 inhibitors are highly valuable in women with metastatic hormone receptor positive HER2 oncogene breast cancer, the Monarchy Trial was one of two major presentations at San Antonio that tested a CDK4/6 inhibitor, in this case abemaciclib, as an addition to endocrine therapy in early high-risk breast cancer. And as you may remember, and as some of our listeners may recall, in late September 2020, monarchE was actually presented at the ESMO meeting and was simultaneously published in the Journal of Clinical Oncology. It was a highly positive trial, and it was updated at San Antonio. And what they did was they randomized over 5,600 women with hormone receptor positive, HER2 oncogene negative early breast cancer to either receive standard endocrine therapy alone or standard endocrine therapy with abemaciclib. Hormone therapy continued for 5 to 10 years. That was physician choice, but the abemaciclib was continued for the first 2 years. They selected a group of patients with breast cancer who were at high risk for an early relapse. Patients who had at least 4 positive lymph nodes were eligible, but also patients with 1 to 3 positive lymph nodes who had a primary tumor of at least 5 centimeters in size or had high histologic grade. And that whole group was considered cohort number 1. There was a second cohort of high-risk women, however. Cohort 2 included women who had 1 to 3 positive lymph nodes and the Ki-67 of greater than 20%, but not a tumor of 5 centimeters or a tumor with high histologic grade. And they analyzed the two cohorts separately, giving an indication of whether a high Ki-67 was a meaningful selection criterion and or whether one cohort had differential benefit from abemaciclib in comparison with the other. And what they found, as I know you recall, at ESMO in September, at a median follow-up of 15.5 months, the addition of abemaciclib to endocrine therapy reduced the risk of invasive disease by 25%. The current update, with a median follow-up of 19 months, so about 3.5 months longer, indicated that the results of treatment actually improved a little since September. Compared with patients who received endocrine therapy alone, those who received abemaciclib had a 28.7% reduced risk of invasive disease. The 2-year IDFS rate with the combination arm and the endocrine therapy alone arm were 92.3% and 89.3% respectively, an absolute difference of 3%. Further, the researchers observed an improvement in the 2-year distant relapse-free survival rate with abemaciclib, 93.8% compared to 90.8% with endocrine therapy alone, again, an absolute difference of 3%. Among the almost 2,500 patients with centrally assessed high Ki-67, there was even more of a differential benefit in outcome with abemaciclib. Among the patients in that cohort, those who received the combination treatment had about a 31% decreased risk of invasive disease compared with those who received endocrine therapy alone. The 2-year IDFS rate in the combination arm and endocrine therapy alone arm were 91.6 and 87.1% respectively, and that's an absolute difference of 4.5% for a hazard ratio of 0.691. Now, with regard to distant relapse-free survival, in the cohort with high Ki-67 of greater than 20%, the hazard ratio was even a little better in favor of abemaciclib, a result that was even more statistically significant. The most frequent adverse events were predictable. They were generally mild. They were stable since September. There were about 28% of patients who had to discontinue abemaciclib early because of an adverse event, but there were many more patients who required dose delays, dose reductions, or both. Only about 15% of the patients discontinued endocrine therapy. And interestingly, most adverse events occurred in the first 5 months, and most patients were able to stay on study drug for the entire duration of the 2 years, for those who actually had already been required to stay on it for 2 years. Now, why this is important is that if it's true, this is the first real advance in hormone receptor positive breast cancer adjuvant treatment in many years. And this has the potential to save several thousands of lives. And it's encouraging that the IDFS rate and the distant relapse-free survival curves are splitting farther apart with time. The study authors mentioned that they plan to go to the FDA within the next year for an approval for abemaciclib in the adjuvant setting. My concerns are somewhat similar to the same concerns I voiced after the ESMO meeting. This remains a very early look at the data. Median duration of abemaciclib was just over 17 months in this update and 18 months for endocrine therapy. As one speaker mentioned in San Antonio, this was a planned analysis, but it probably shouldn't have been designed for such an early look, since relapse in endocrine sensitive breast cancer occur over a period of many years. In another study that I'll discuss in a minute from San Antonio, the data looked great for the CDK4/6 inhibitor at 2 years, and then the IDFS curves came together and ultimately were superimposable. As you know, central performance of Ki-67 is terrific, but Ki-67s are not done reliably at many institutions now. The cutoff of 20% for Ki-67 in this study was really a high one, and perhaps that further enriched the population for early relapse. In fact, a legitimate question in this study and in the one that I'm about to bring up was whether these were patients who already had micrometastatic disease. And that would be a setting in which a CDK4/6 inhibitor would be expected to show benefit in the first 2 years over endocrine therapy alone. In summary, most of the comments made by discussants at San Antonio suggested caution. You know, as impressive as the study results were, they suggested caution. We have to discuss the results of the study with our patients, but it may be just a little bit early to jump to the conclusion that wholesale use of adjuvant abemaciclib in high-risk early breast cancer should be standard care.
Sounds like it's probably going to pan out based on, of course, the metastatic setting and how it works there. But I was interested as you went through AEs, adverse events, they're not insignificant. And
no, they're not.
So I agree, that's positive, but let's wait it out.
And one would think that if one were to use abemaciclib, it probably should be abemaciclib rather than another CDK4/6 inhibitor. It probably should be in people who exactly would have qualified for this study.
All the data.
The second one that I wanted to bring up, kind of along the same vein, was GS1-02. This was the PENELOPE-B trial, a phase 3 study of palbociclib combined with an endocrine therapy in hormone-sensitive breast cancer patients who had high relapse risk after neoadjuvant chemotherapy. And the background for this one is that, as you know, complete pathologic remissions from neoadjuvant chemotherapy are uncommon in women with hormone receptor positive breast cancer. And getting complete pathologic remissions is less tied to relapse rates and survival in them than it is in triple negative or in HER2 positive breast cancer patients. However, it's still significant when women with hormone receptor positive breast cancer have residual disease at surgery, since about a third of them will ultimately relapse and die of their breast cancer. So it's important to try to improve outcome in these women with residual disease after neoadjuvant therapy. It's actually interesting, the risk of relapse can be assessed more accurately in this patient population using something called the CPS-EG scoring system that was published by Middendorf and coworkers in the JCO in 2011. And what they did in the PENELOPE-B trial is they randomized 1,250 women who had completed neoadjuvant chemotherapy and local regional treatment to receive either 13 monthly cycles of palbociclib at a standard dose and schedule, or a placebo plus endocrine therapy. The type of endocrine therapy was per investigator choice, as it was in the Monarchy trial. Stratification variables for this one were lymph node status at surgery, age, Ki-67, which was done centrally, global region, and the CPS EG score. The primary endpoint was invasive disease-free survival, just as it had been in Monarchy. The women in this trial were really at high risk for relapse. 95% of them had positive lymph nodes after neoadjuvant chemotherapy. The majority had moderately high CPS EG scores of at least 3, and about half had high histologic grade and/or an elevated Ki-67 after neoadjuvant chemotherapy. They followed these patients for a median of about 3.5 years at the time of this report, 43 months, much longer than the Monarchy patients had been followed. And what they found was that the 4-year IDFS rate was a little more than 73% for the patients receiving palbociclib plus endocrine therapy, and about 73% for patients receiving placebo plus endocrine therapy. The difference between the arms in IDFS appeared greater at 2 years in favor of the palbociclib, slightly less at 3 years, and then at 4 years, no group could be identified that had benefit from palbociclib. 74% of the relapses were distant. An overall survival interim analysis that was planned showed a hazard ratio of 0.87, which was not statistically significant, with an overall survival of 96% for palbociclib and 95% for placebo. And why this is important is that the PENELOPE-B trial, while it's considerably smaller than Monarchy, has much longer follow-up, with a median follow-up of about 43 months, and the addition of 1 year of palbociclib to endocrine therapy in patients with hormone receptor positive, HER2 oncogene negative breast cancer at high risk of relapse after neoadjuvant chemotherapy did not improve IDFS or overall survival. The most interesting thing about the IDFS curve was that the difference between the two arms was meaningful at 1 year, was a little better at 2 years, but less at 3 years and non-existent at 4 years. Was it that the placebo arm performed better than expected? No. The 3-year IDFS rate in the placebo arm was exactly what had been predicted for them. Was it that the patients receiving palbociclib stopped the drug prematurely? Not really, although the duration of the CDK4/6 inhibitor in this trial was only about a year. Adherence to therapy was actually really terrific. It was over 85%. Long-term follow-up from this trial and from the adjuvant studies is going to be important, as will the translational and subgroup analyses that are ongoing. But several of the discussants who commented on PENELOPE-B, as well as Monarchy, suggested that these populations probably already have metastatic disease. And that's why the drug looked good at 1 year and 2 years and then failed to perform thereafter, which is exactly what you would expect. The critical issue for all of these CDK4/6 inhibitor adjuvant trials, as Dr. Sarah Hurvitz said at the meeting, is follow-up, follow-up, follow-up. Hormone receptor positive breast cancer therapy is a marathon. In the case of Monarchy and the Palace trial that was presented as a poster at this meeting, we've just completed a sprint.
Yeah, and I'm thinking as you're beautifully laying it out, that's really, it's early. It's probably going to perform better than without it, but do they already have metastatic disease? And we're just getting an early start. So, but I'm sure it'll be the subject of many meetings to come. All right, so good job. Let me take the next two. And this next one is from Joe Sperano, wonderful investigator nearby here up in New York at Montefiore. It's GS4 after number 10, entitled Development and Validation of a Tool Integrating the 21 Gene Recurrence Score and Clinical Pathologic Features to Individualize Prognosis for Distant Recurrence and Prediction of Absolute Chemotherapy Benefit in Early Breast Cancer. So a long title, but it's actually simple what he did, but really elegant. We all know the RS score, the recurrence score, the Oncotype DX genomic health, and then to develop this thing they call the RsClin, 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 they added to the RS score the grade of the tumor size, and the patient's age. And they decided or hoped to be better predicting distant recurrence and chemotherapy effect than just that RS score by itself. All these patients were typically what we send our genomic health assays for. They all are estrogen receptor positive, HER2 negative, lymph node negative. So they came up with this that looked good. Then to make this presentation, they then took a large real world data set and applied it, just the RS or the RsClin, this combination of RS plus grade, tumor size, patient age. And they found that it did what they hoped it would do, perform better. And distant recurrence and chemotherapy effect were more accurately predicted in this real world data set than the RS score itself. So it's actually, when I was listening, you can apply the formula. What formula? Well, you go to the Genomic Health website, where we all tend to go to look at our Oncotype DXs, it's there. So you can try it yourself at home or in the office to plug it in and see if you agree. Nice presentation that this might predict better how your patient might do DR, distant recurrence, or CTX, chemotherapy effect, which is what these discussions are all the time with our patients as we get our Oncotype DX. But I know coming soon, in an abstract or two from now, you're going to do the RxPONDER analysis, which I can't wait to hear. So my next one, my affinity, Alan, for tumor markers, circulating tumor cells in this next abstract, GS4, number 08, entitled Clinical Utility of Repeated Circulating Tumor Cell CTC Enumeration as Early Treatment Monitoring Tool in Metastatic Breast Cancer, a global pooled analysis with individual patient data. Dr. Wolfgang Jani from University Hospital Ulm in Ulm, Germany, was a presenter. And these were all metastatic breast cancer patients, and they were on treatment. And these CTCs were done at start of therapy. And then they planned a 35-day median. Actually, their presentation was a median of 29 days later, so 4 weeks later. You would do this CTC analysis at study entry, and the median was 4 weeks later. All subtypes were included: estrogen receptor positive, HER2 positive, triple negative breast cancer. And so the outcome was really fascinating. Listen to the numbers. They had 4 types. So you were negative at the beginning. So I'm going to give you the beginning and a median of 29 days later, just 4 weeks later. You were negative for CTCs. You were negative positive. You were positive negative, or you were positive, you stayed positive. And you might expect that would be the worst, and it was. So for all subtypes that I just mentioned, ER positive, HER2, or triple negative, median overall survivals in months. For negative, 47 months. Negative turning positive, 29 months. Positive turning negative, a little better, 32 months. And as expected, positive staying positive, 17 months. There were slight differences, nuances in the presentation of the ER positives or the HER2s or the triple negatives, but the same theme occurred with overall survival, and the worst being positive. In fact, I was struck by, if you were a triple negative and you were positive at the beginning and positive 4 weeks later, you had a 4-month overall survival. So that was interesting. We don't have this yet available. I know it's been available in some format for some time, but I thought fascinating that you might be able to say to a person, besides measuring a CEA or CA125 or the 27, 29, 15, 3, the others that we use, here's something really somewhat predictive on how you might do and have to change therapy. So really interesting. I will then give it back to you, anxiously waiting to hear the RxPONDER, and I think we do have time for the ADAPT trial.
Okay, that sounds great, Dave. And by the way, with regard to the CTCs, one would wonder whether or not maybe they might have some value in the adjuvant setting, where you really can change therapy kind of in midstream.
Oh, of course, sure. And those micrometastatic people are detectable. At ESMO, speaking of which, in colon cancer stage 2s, whom we don't usually treat, there was this circulating DNA, same kind of thing,
right?
That might predict the stage 2s, who might be those you might treat. So stay tuned for that podcast sometime later.
You bet. The next one I wanted to do was GS3-00. This was a late-breaking abstract of the SWOG 1007 trial, also known as the RxPONDER trial, as you've mentioned. This is a phase 3 study of standard adjuvant endocrine therapy with or without chemotherapy in patients with hormone receptor positive, HER2 oncogene negative breast cancer, 1 to 3 positive lymph nodes, but with a 21 gene recurrence score of 25 or less. And RxPONDER could be the most important and most provocative study that was reviewed at this meeting.
Yeah.
Many of us think of RxPONDER as the node positive first cousin of the Taylor RX trial, that you mentioned a few minutes ago. Retrospective analysis of SWOG 8814 suggested that perhaps postmenopausal women with a small number of positive lymph nodes and low genomic risk scores could avoid receiving adjuvant chemotherapy, but it's not really been tested prospectively, and RxPONDER set out to determine prospectively which patients in that category could safely avoid chemotherapy and achieve similar outcomes with endocrine therapy alone. The study chairs chose to study a group of women who, despite having positive axillary lymph nodes, had otherwise favorable tumors on the basis of a low or moderately low Oncotype DX recurrence score. And what they did was they randomized over 5,100 patients, almost 5,100 patients with 1 to 3 positive axillary lymph nodes and whose tumor tissue had a recurrence score of 25 or lower to endocrine therapy alone or adjuvant chemotherapy followed by endocrine therapy. Randomization was stratified by recurrence score, either 0 to 13 or 14 to 25, by menopausal status, and by type of axillary surgery. Roughly 2/3 of the women were postmenopausal, and they received either tamoxifen or an AI as their endocrine. The premenopausal patients were predominantly treated with tamoxifen alone for their hormonal therapy. The data were reported after an independent data monitoring committee directed that they release the results, despite the fact that only a little more than 50% of the expected IDFS events had occurred to that point. And therefore, these are the first results of RxPONDER, but not the final results of RxPONDER. However, having said that, what they reported was that at a median follow-up of just over 5 years, there was no association between chemotherapy benefit and recurrence score values between 0 and 25 when evaluating the entire study population. Now, there was a significant association between chemotherapy benefit and menopausal status, however. In postmenopausal patients with recurrence scores of 25 or lower, there was no difference in the 5-year IDFS rates between those who received chemotherapy and those who did not, an IDFS rate of 92% with or without chemotherapy. In the premenopausal patients, though, with recurrence scores of 25 or lower, chemotherapy was associated with a 5-year IDFS rate of 94.2% versus 89% for those who did not receive chemotherapy, about a 5% absolute difference. The data also showed an overall survival benefit in premenopausal patients, although the result is considered early due to the fact that there have been few deaths to this point at the time of evaluation. But the hazard ratio, I thought, was pretty stunning, 0.47 in favor of chemotherapy for overall survival in premenopausal patients. Now, the results were similar in premenopausal women with recurrence scores of 0 to 13 and those with recurrence scores of 14 to 25. In premenopausal patients, it was interesting, ovarian suppression was performed in about 16% of the women receiving endocrine therapy alone, but only in about 4% of patients receiving chemotherapy, since twice as many of them went through a chemotherapy-induced menopause. And why this is important is that these data really establish that postmenopausal women with between 1 and 3 positive lymph nodes and an Oncotype DX score of 25 or less do not need postoperative adjuvant chemotherapy. End of discussion. For physicians who have been giving those women chemotherapy, these data are immediately practice changing. The majority of postmenopausal women in this trial actually had 1 or 2 involved nodes, so one could legitimately question whether the initial results will hold up in women with 3 positive lymph nodes. That remains to be determined. Our listeners will recall that in the MINDAC trial, postmenopausal patients with high clinical risk and low genomic risk did very well if they received endocrine therapy alone, regardless of lymph node status. Now, premenopausal women with 1 to 3 positive nodes and an Oncotype DX recurrence score of 25 or less should receive adjuvant chemotherapy. There was a meaningful difference in IDFS and an early but eye-catching hazard ratio for improved survival with chemotherapy in premenopausal women. Was the benefit of chemotherapy in them just a reflection of chemotherapy-induced menopause? Possibly. I don't think we can really know for sure. But it's interesting that there was no relationship between continuous plots of recurrence score and chemotherapy benefit. You'd kind of expect, on the basis of the Taylor RX trial that you mentioned, that chemotherapy benefit would be greater in women with higher recurrence scores, as it was in Taylor RX for node-negative patients. Dr. Meredith Reagan, a biostatistician, reflected that the data in premenopausal women suggested the recurrence score is affected more strongly by the estrogen module than by the proliferation module of the Oncotype DX score. And this would support the view that suppression of ovarian function is really the key benefit from chemotherapy in premenopausal women in RxPONDER. The study authors are ultimately going to be doing an analysis to see if there is a difference in outcome among young women who did or did not experience a chemotherapy-induced menopause. Since the overall survival information is immature and more than half of recurrences occur in this type of breast cancer beyond year 5, follow-up is ongoing. It's going to be ongoing for 15 years. And I think we can expect many more practice-modifying or practice-changing information and data to come from RxPONDER for the years to come.
Fascinating. I heard it presented also, I could see a 24-25, let's have a chemotherapy talk, but how about the one with a 5? Who's
Yes.
Premenopausal. The lymph nodes bother you. They always have bothered us, but here now is stronger data in that premenopausal, 2 lymph node positive, score of 5. Hey, let's talk chemotherapy. There's going to be some more office discussions.
A lot more.
Right.
The next one I wanted to go into was abstract GS4-04, General Session 4, 4th abstract. Endocrine therapy alone in patients with intermediate or high-risk early breast cancer, 0 to 3 positive lymph nodes, recurrence scores of 0 to 25, and Ki-67 response after preoperative endocrine therapy. This is the ADAPT HR-positive, HER2-negative trial. And the background for this one is that in hormone receptor-positive, HER2-negative, node-negative early breast cancer, patients with a low Oncotype DX recurrence score have an excellent prognosis and do not benefit from adjuvant chemotherapy. From the RxPONDER trial, we know that most postmenopausal patients with a small number of lymph nodes and a low Oncotype DX recurrence score present another group that derive no benefit from adjuvant chemotherapy. The question that ADAPT tried to answer, and that several other trials at San Antonio sought to answer, is whether endocrine therapy response-guided criteria could also play a role in selecting a group of patients who don't require chemotherapy. And what they did in this trial is they treated almost 4,700 patients with hormone receptor positive, HER2 oncogene negative, clinically high risk early breast cancer with about a month of standard endocrine therapy as neoadjuvant treatment. Now, those patients whose recurrence scores pre-treatment were 0 to 11 continued endocrine therapy alone with no planned chemotherapy at all. Those patients with a pre-treatment recurrence score of 12 to 25, though, received their month of endocrine therapy, and then they had a core biopsy of their residual cancer. If the post-endocrine therapy core biopsy showed that the Ki-67 had dropped to less than 10%, patient continued endocrine therapy alone. If the post-endocrine therapy core biopsy showed that the Ki-67 remained greater than 10%, or if the patient had clinical N2 or N3 lymph nodes, the patient was assigned to receive neoadjuvant chemotherapy. In this trial, they defined high risk as a tumor that was T2 to T4, or clinically node positive, or high histologic grade, or high pretreatment Ki-67 of over 15%. And the primary objective was to see if there was non-inferiority of the 5-year invasive disease-free survival of patients with an intermediate recurrence score of 12 to 25 and endocrine response by Ki-67 in comparison with those who presented with a low recurrence score of 0 to 11. And what they found was that the 5-year IDFS was almost 93% in those with intermediate recurrence scores and Ki-67 response, and about 94% in the patients with the low recurrence scores of 0 to 11. Therefore, the pre-specified criteria to accept non-inferiority was met in this trial. IDFS was about 96% in both the patients with recurrent scores of 12 to 25 and Ki-67 response, and in the patients who started out with a lower recurrence score of 0 to 11. And I said IDFS, but I meant distant relapse-free survival was about 96% in both groups. 5-year overall survival was 98% versus 97%. In multivariate analyses in those with recurrent scores of 0 to 11, regardless of lymph node involvement or menopausal status, IDFS, distant disease-free survival, and overall survival was excellent. But in the patients with the intermediate recurrent scores of 12 to 25 and Ki-67 response at 4 weeks, patients with 0 to 2 positive lymph nodes did very well. Those with 3 positive lymph nodes did not do nearly so well with endocrine therapy alone. And that small group, which was just about 7% of the overall population, the 5-year distant relapse-free survival was 76%, so much lower than for women with 0, 1, or 2 involved lymph nodes. And why I felt this study was important is that the primary endpoint was reached. Patients with a recurrent score of 12 to 25 and endocrine response after a short pre-op course of endocrine therapy had a terrific 5-year IDFS rate, and it was comparable to those with 0 to 3 positive lymph nodes and a recurrent score of 0 to 11. The outcome was similar regardless of age, as long as the patient did not have 3 involved nodes. Outcome was related to recurrent score, but not related to the presence or absence of involved nodes. So the Oncotype DX recurrent score could spare the majority of hormone receptor positive, HER2 oncogene negative patients with 0 to 3 positive nodes from receiving chemotherapy, and Ki-67 monitoring demonstrated some potential to identify yet another group of patients who might be able to be spared the toxicity of chemotherapy. But what was pointed out by the discussant for this talk, Dr. Lajos Pujdai, there are a few elephants on the table. And one of them is that it's not really clear just how much predictive value early response assessment actually adds to the gene expressing profiling alone, because about 75% of patients with the intermediate recurrence scores had a Ki-67 response by week 3 to 4. The ADAPT trial did not assess how well the group that did not have a Ki-67 response did in comparison with those who did. As you probably know, and as I suspect our listeners know, Ki-67 is actually not a very strong predictor of pathologic complete remission rates, and measurement of Ki-67 in community hospitals is unreliable with lots of inter-observer variation. So many hospitals have stopped reporting it, as we discussed earlier. The bottom line here is that selection of chemotherapy versus no chemotherapy in hormone receptor positive patients with 0 to 3 lymph nodes has to be based on age, menopausal status, and baseline recurrence score, or some similarly validated molecular assay. It's worth studying whether another group of patients could be spared treatment with chemotherapy, but even after the ADAPT trial and some similar studies that were reported at San Antonio, just how much predictive value early response assessment adds to gene expression profiling is really not completely clear.
Well, yeah, that sounds like that was the way you're going to bring it on home. So I think as much as we'd hoped for that Ki-67, not really groundbreaking in this study, different from the RS score.
Yeah, I don't think that it changes what we do on Monday morning, as they say.
Okay. All right. Well, that was beautifully presented, and I'll bring it on home for the last two. And so next to last is GS301, additional efficacy endpoints from the phase 3 Keynote 355 study of pembrolizumab plus chemotherapy versus chemotherapy alone as first-line therapy for locally recurrent, inoperable, or metastatic triple negatives. These are all triple negative people, presented by Hope Rugo. And a very important key finding here that they're going to present is their CPS score and how that tells you what might turn out by this therapy with or without the pembrolizumab. CPS, combined positive score. It's actually a really simple idea. You take a spot of tumor cells and you mark them up for PD-L1. You count that number and divide it by the total number of tumor cells, you get a number. So if it's 50 out of 100, the number is 50. If it's 1, you get the idea. So that the 355 Keynote pembrolizumab always adds to the chemotherapy. We knew that. The point of this study was to say, well, can we hedge our bet. How about that CPS does add anything in addition? Remembering that the chemotherapy backbones were nab-paclitaxel or paclitaxel or gemcitabine carboplatin, and with or without pembrolizumab. And the key is the finding at the end here. And I'll just read what I took away from this in their conclusion. In the subgroup analysis, which you're about to hear the CPS score, the PFS with pembro plus chemo, and the backbone really didn't matter much, compared to chemo alone, always favored the combination with pembro and the chemotherapy. But how about that CPS score? Well, I think this is similar to what we know in, for example, lung cancer, the PD-L1. If your CPS score was over at least 10 or more, these are PFS, progression-free survival outcomes of months, you were median 9.7 CPS score over 10 versus chemo only 5.6, 9.7, 5.6 months. If your CPS score were lower, so 1 or above, as you might expect, the pembro and chemo was 7.6 months median survival versus that baseline 5.6. So it's better to have a higher score, and that's the takeaway from this particular study, that we know in triple-negative breast cancer, the checkpoint inhibitor, in this case pembrolizumab, clearly plays a big role. So Alan graciously gave me the last abstract because he knows my affinity for this sacituzumab, where we both sat together at ASCO a couple of years ago in Chicago, spellbound as the best of the day presentation went up about this molecule and its effect in triple-negative breast cancer. So GS3, abstract 6, biomarker evaluation in the phase 3 ASCENT study of sacituzumab govitecan versus chemotherapy in patients with metastatic triple-negative breast cancer, presented by Sarah Hurwitz from UCLA. And what did they say? Well, to remind you, this neat marker, trophoblast cell surface antigen 2, or TROP2, is highly expressed on some tumor cells, especially triple-negative breast cancer. This molecule, this combination antibody-drug conjugate, is an anti-TROP antibody, so it goes and finds the tumor cells. And coupled to it is the SN38, it's an active metabolite toxin of irinotecan. And here they report their sub-analysis giving the sacituzumab day 1 and day 8, the dose which actually is labeled in the US, 10 milligrams per kilogram on every 3-week repeat, versus single agent treatment, physician's choice, in this triple-negative metastatic who've had 2 cycles, 2 regimens or more. And the comparative physician's choice was capecitabine or eribulin or vinorelbine or gemcitabine. So what happened? Well, so they did an analysis of the TROP2 level in your tumor and tried to decide if that predicted you would respond better or not. And of course it did. And they coded these levels for TROP2 on the tumor as low, intermediate, or high. And the number was less than 100, 100 to 200, or 200 to 300. Actually, about 50% or more of the patients were that high number, 200 to 300. So listen to these numbers. I'll bounce back and forth with or without the drug antibody conjugate, depending on their TROP2 level marker. So here we are, PFS in months, 2.7 versus 2.6, not too big a deal. Now, if you're intermediate score, 5.6 to 3.2, if you're a high score, 6.9 to 2.5 progression-free survival months. And they also presented overall survival data. And we'll again do low, intermediate, high TROP2 scores, as they call it. So here we are in months, median overall survival, 9.3 versus 7.6. Median intermediate expression, 14.9 versus 6.9 months. And if you're high, again, 14.2 versus 6.9 months. So I think, remembering back to estrogen receptor positive, that's where tamoxifen works, one of our first biomarkers. We're getting closer and closer to not having to put a patient through and maybe run an expense unless we know we can hedge our bet that a tumor is highly enriched with something that the drug, in this case, a drug antibody conjugate, might work against. So I thought those were fascinating results. And with that, any thoughts as we bring to a close and let our poor listeners try and digest all these wonderful abstracts from San Antonio? Did you enjoy the meeting?
I love the meeting. I love it more in person, I must say, compared to the virtual meeting. But there was still plenty of science. There were over 850 abstracts. And the discussions were terrific. The discussions were great, and the questions and answers were great. I would say that the one thought that I had as I thought about all of this, Dave, was that this meeting really establishes that people who participate in clinical research trials really are first in line for getting advances in therapy. You know, having the opportunity to participate in a clinical trial is a really important advantage to a patient. We have these posters in our waiting rooms to try to popularize clinical trials, and one of them says, be first in line when it really matters. When you think about some of the positive results that we discussed today, that is really true.
Isn't that an interesting thought? I like that, be first in line. You know, COVID, as we're recording this in December 2020, COVID is surging. Our research, probably similar to yours, shut down at about April through about September because it was just too dangerous. So a gap in all of our research, probably around the world, now coming back online. To the credit of all of our investigators, I saw so many universities, yours, mine, pivot and try and understand what COVID was doing to our patients who are getting on clinical trials and or just what's happening to our patients who have cancer. So I think San Antonio, once again, was a really wonderful meeting. I hope our listeners have enjoyed these 10 abstracts. They'll be on the website with show notes, mdedge.com/hematology-oncology. You've been listening to Blood and Cancer, and my wonderful colleague and friend for so many years, Alan Lyss, who's subprincipal investigator at the Heartland Cancer Research NCORP and associate professor of clinical medicine at Washington University. Alan, thanks so much for doing this again. Wonderful to work with you.
I love doing this with you, Dave. Thank you for asking me.